All right, we just hit the top of the hour, so we will go ahead and get going. Hi, everybody. Good afternoon. My name's Troy Jorgensen. I'm the program manager for Project Echo Nevada. So glad you could be joining us here today at our Geriatrics Echo series. So we'll start off with some introductions of the Hub team members and subject matter experts that we have speaking today. We'll go out to all of you and ask you to introduce yourselves so we can get to know you a little bit and who we're speaking to. Then, of course, always through Project Echo, our goal is to support you all as providers and practitioners throughout Nevada with your own patients and any questions that you might have about specific patient cases or just general questions in general. And then we'll get into the didactic presentation on the crossovers between geriatrics and palliative care. So again, my name is Troy Jorgensen. I'm the program manager for Project Echo Nevada. Jessica, if you could introduce yourself, please.
Hi everyone, my name is Jessica Kate. I'm one of the geriatric clinical pharmacy specialists at the VA in Reno. I work with the community living center with our geriatric patients in hospice and palliative care, and I also do home-based primary care as well. And I'll be speaking today with the geriatric team.
Thanks, Jessica. Leslie?
Hi, my name is Leslie Baker. I am the geriatric pharmacist at the Sanford Center for Aging, and I am also on the geriatric interdisciplinary ECHO team.
Thanks, Leslie. Kelly McMillan? Oh, just a second here, Kelly.
There you go. All right. Hi, Kelly McMillan. I'm a social worker, work at the Sanford Center for Aging. I'm part of our geriatric assessment team.
Thanks, Kelly. And Kelly Presser?
Hi, I'm Kelly Presser. I'm a clinical nurse leader. I work at the Reno VA, and I'm a member of the geriatric ECHO team.
Thanks, Kelly. Dr. Levy?
Good afternoon, everybody. Mordechai Levy here. I'm a practicing geriatrician, physician expert here on the geriatric ECHO Hub team. See outpatient consults with Kelly and Leslie through the Sanford Center of the Aging, doing outpatient geriatric consults. Really excited today that we have Jessica joining us as well as a kind of guest expert from the palliative care ECHO team to help us kind of compare and contrast our specialties. So again, happy to see everybody today.
Thanks, Dr. Levy. Patty?
Hi, this is Patty Swagger. I'm the director of the Nevada Geriatric Education Center and Clinical Education at the Sanford Center for Aging and serve on the Geriatrics ECHO team.
Thanks, Patty. And Sneha?
Hi, I'm Sneha Sharma. I'm the program coordinator for Project Echo Nevada.
Thanks, Sneha. All right, so that's our ECHO team for today. So we'll go out to all of you and ask you to introduce yourselves. Melania O'Brien, you're the first on my screen. Could you unmute yourself and introduce?
I am Melania O'Brien. I'm a long-term care administrator.
Thanks, Melania. Good to have you joining us today. Next is Rick. Go ahead.
Hi, my name is Rick Obringer. I'm a physician assistant in Las Vegas.
Thanks, Rick. Always good to have you. Amy?
Hi, I'm Amy Thompson. I'm the Cancer Survivorship Programs Manager at Nevada Cancer Coalition.
Thanks, Amy. Fee Neal's next. Fee, doesn't look like you've joined the audio yet, though. So just make sure you click the little microphone icon on the lower left corner of the Zoom toolbar, and we'll be able to hear you today. Next is Lisa Meyer. Lisa, looks like you're joined on telephone. I'll click unmute, and we should be able to hear you. Go ahead, Lisa.
Hi, I'm Lisa Meyer. I'm administrator for Marquee Plaza Regency in Las Vegas.
Thanks, Lisa. Good to have you joining us today. Megan Jackson.
Hi, this is Megan. I work with aging and disability with the community-based care unit.
Thanks, Megan. Good to have you today. M.L. Rubenstein.
I'm Michelle Rubenstein, MSW. I work first year regional center in Reno.
Thanks. Good to have you. Sandra Solis.
Hi, I'm Sandra Solis. I am a pre-med student and an AHEC scholar in Elko.
Thanks, Sandra. I think it's Sarah Tobin.
Hi, good afternoon. My name is Sarah. I'm a social worker in Las Vegas, working with Dignity Health Medical Foundation. care coordination.
Thanks, Sarah. Good to have you. And then last is Vanika.
Hello, good afternoon, everyone. My name is Vaniqua. I'm a medical licensed social worker with ProCare Hospice of Nevada.
Great. All right. Thanks, everybody, for bearing with us through introductions. Great to have such a diverse group today. So yeah, as I mentioned, really our goal through ECHO is supporting you in your patient interactions, in your patient care, and giving you an opportunity to discuss questions or issues with our entire team of experts that we have here today. So does anybody have anything that they want to run by the team? If you do, please feel free to unmute yourselves with the microphone icon on the Zoom toolbar. You can also write in through the chat box. Yeah, Rick, go ahead.
I'll toss a few questions out there since no one else is. I'll just ask two questions real quick if someone could speak to it. One, over the weekend, I was speaking with a very close family friend. Her husband's in home hospice for dementia, and she only gets respite care if she puts him like in a nursing home, I guess, for the number of days she's going to take for her respite care. And she said she read or heard that they're putting COVID patients in nursing homes. I didn't know if that was a conspiracy theory or a real thing that's taking place. She made it sound like it was a real concern. If anybody has any info on that. And secondly, I'd like to ask Amy a question from the Nevada Cancer Coalition. There was a TV commercial last night. I caught my attention, Cancer Centers of America, I think it was, based in Phoenix, and kind of took a swipe at waiting times in Las Vegas to get to access to care at cancer places. And kind of like, hey, if you're sick of the long waits in Las Vegas, and the TV commercial mentions Las Vegas by name, you know, consider how quickly we get things done down here. So I wanted to know if that was an issue, if access to care in the cancer area is a real issue here in Las Vegas.
Thanks, Rick. Great questions. Let's address the COVID in nursing homes first.
Mordechai Levy here. I haven't heard anything about you're saying that they're housing COVID-19 positive patients in a nursing home as kind of isolation. Rick, you're still muted, sorry.
Looks like, yeah.
Sorry. Yeah, she's caring for her husband with home hospice, and she's reluctant to accept the respite care because that involves putting him in a nursing home. And so she has this concern that, and she's a bit of a conspiracy theorist anyway. And I was like, I'm gonna have to look that one up. I know that sounds a little out there to me, but I didn't know.
So in general, the CDC is making recommendations that if you have a congregate living facility with elders and you do start to have COVID-19 positive patients, that they cohort those patients if possible, or you kind of put them all in the same hallway, get them all the same type of care. And I'm not aware of any kind of nationwide, or this may be facility specific, where they kind of, if you have a COVID-19 positive patient, you'll send them to a nursing home. In general, we generally try and separate the two populations, if you have COVID-19 and if you don't have COVID-19, to kind of avoid the ability for essentially for disease transfer. And so I would be very surprised to kind of hear that they were putting people without COVID-19 into a facility with COVID-19, especially in the same cohort or same hallway. But I guess I wouldn't be as surprised if it was in the same actual facility, just because I think it would be tough to move people. I know we have Kelly and Jessica here that work in the VA nursing home, and so I'd love to hear what they have to say as well.
Yeah, this is Kelly. So I actually just got off of a call from the CDC talking about infection control practices in long-term care settings, and they suggested exactly what Dr. Levy had mentioned of cohorting any COVID positives and any negative. It would certainly depend on the nursing home if they were to have a case, an outbreak, in which case I think it's been very different. Hearing from some nursing homes will prioritize keeping those residents, and some will immediately ship them out to a local hospital. And it also depends on the severity of their illness and their goals of care, of course. So I would feel very safe in saying that I think general practices for all nursing homes would be to have a very separate area where if they were housing COVID positives, they also would have very separate staff taking care of those individuals. So there'd be no crossing of staff or nurses caring for COVID positives and COVID negatives. And CDC is recommending real physical barriers between the two as well. So completely different wings of the nursing home or the unit or whatever is possible. And your friend or family could certainly call and inquire what their practices are and what they're doing for screening and testing and sort of what they're doing to mitigate any risk to their residents.
The pandemic of fear is real.
Yes.
Thanks, everybody. Amy, any comments on that ad? Oh, Patty. Yeah, Patty, go ahead.
I was just going to say, I wonder if there was some confusion on her part, because there is, and Kelly Macmillan might be able to comment on this, but there is some additional funding that is related to COVID funding to provide additional respite. So I wonder if that might be some misunderstanding on her part as well.
So this is Kelly Macmillan. There is some funding, some additional funding for caregiver resources, I can look that information up and put it in the chat box for you. That'd be helpful to you.
Yes, please. Thank you.
Sure.
All right, Amy.
Here we go. Yes, Rick, I live in Reno, so I have not seen that ad that you're referring to, but I'm very curious now. I might have to do some research into that. So I can't really speak to that specifically. I do know that medical oncology offices across the board have obviously had to change things in light of the current pandemic in terms of triaging patients and using more telehealth when they can, things like that. But specific to that, Cancer Centers of America, I do not know. So I would have to look into that.
Thanks for the question. Any other questions or specific patient-related issues that you'd like to discuss? Please feel free to unmute yourselves or write in through that chat box. All right, I think we'll go ahead and get started with the didactic then. And of course, we'll have some time for Q&A at the end of this. So this is our disclaimer, just letting you know that we do record all of these sessions. If you don't want to be on the video that we post, just let us know through the chat box and we can edit you out. And then this is a reminder, just if you do present a patient case, please just don't disclose any protected health information since we're in a group setting today. All right, so Patty, could you talk a little bit about the survey?
Sure. I think many of you have participated in our echoes before, but we do receive federal funding and they want to know the types of people who attend our trainings. So we are asking that you complete the demographic form, and if you only need to complete it once. So we encourage you to go to that link and fill it out for us. We really appreciate it. Thank you so much.
Thanks, Patty. I sent out the link for that through the chat box. So again, if you've already completed it for us, we appreciate that. But if you haven't, please go there and fill that out. All right, I will turn it over to Leslie and Jessica.
Cool. I think I'll be starting today.
Oh, correct.
Then I'll be handing it over to Leslie and then Jessica. So again, my name is Mordechai Levi, geriatrician. Just going to kind of set the stage today while we kind of have this brand new echo, which I'm really excited about, where we're bringing in a member from our palliative care echo team to kind of help show how similar we are in a lot of ways, and also show kind of how different we are. And we thought it would be really great to start off the conversation talking about an age-friendly health system, or the 4 M's. And that's really what I'm going to be talking about today. After I kind of have my little spiel I'll hand it over to Leslie, who will kind of talk a little bit about a case and her perspective as a geriatric pharmacist on kind of how to approach the different things that are kind of thrown her way. And then after that, we'll kind of have a change in clinical condition, and Jessica will start to talk about more of the palliative approach and kind of how similar and potentially different the care approaches can be. So next slide, please, Troy. So just to quickly start, this is kind of an age-friendly health system, the 4Ms model of care. Just by kind of typing into the chat or nod of your head, who here has heard of an age-friendly health system or the 4Ms before? So Amy, I'm seeing a no. Melania, have you heard of an age-friendly health system before?
Dr. Buddy raised his hand.
Cool, thank you. Awesome. So Lisa says no. Cool. All right, so some of us are familiar with it, some of us not so familiar with it. And so the age-friendly health system of care is essentially an evidence-based model on how to take care of an elder across all care settings. And so you can use it in the inpatient, you can use it in the outpatient, you can use it in the nursing home, you can use it on the even as you talk to your families and caregivers and friends. I find to kind of just defaulting on the 4Ms as I conceptually think about the care of this elder to be really, really helpful. And they've broken it down really easily for us as we think about taking care of an elder across their lifespan. Is the first M is what matters. Here it's defined as knowing and acting on each adult's specific health outcome goals and care preferences across settings. This is the most important M. Essentially, it's kind of like a chief complaint, like we would ask at the beginning of any clinic visit, but it really gets down to what people are hoping to get out of their healthcare, or more so what they're hoping to get out of their lives, and what we can do as a medical team to help provide that. The rest of the 3Ms are really our tools to help people obtain what matters. The second one is medications. We'll be focusing a lot on medications today because we have we're fortunate enough to have 2 pharmacists with us. And so making sure these medications are supporting what matters, mobility and mentation. And so if they're not supporting or inhibiting those things, and that makes a big difference to the patient, we really need to consider the appropriateness of the medication. The third M is mentation. Mentation refers to really 3 diagnoses: dementia, depression, and delirium. These are the 3 common, essentially mental health disorders or organic medical conditions that affect elders and can really affect their quality of life and even their mortality. And so, kind of knowing that these are the 3 most important M's is really important, and is really important to use mentation to support what matters as well. The 4th M is mobility. Mobility is really the key to life, kind of making sure that you can stay mobile, keep moving. If that's what matters to you, is really important to most people. And so learning how mobility kind of affects the patient across their care setting and their treatment goals is really important. As we go through the rest of the lecture, what matters is going to change to our patient. And so I want you all to just kind of pay close attention to that as different things happen and people's goals change. What matters changes, and from there on, kind of medication, our treatment plans for medications and mobility will also change. And so wanted to introduce this kind of age-friendly health system. I think Jessica and Leslie will do a great job of just discussing those things with you all. And with that, I want to kind of give a quick opportunity to answer any questions about an age-friendly health system before we move on with the case and hand it over to Leslie. So what questions can I answer about an age-friendly health system? Rick, go for it.
What types of things can be done proactively to preserve mentation?
That is a great question. And I guess you're referring to dementia. So in general, dementia is a syndrome, and so it has lots of different etiologies or causes. And so specifically talking about Alzheimer's dementia, maybe the most common, I guess the most prevalent dementia rather, the exercise and diet are really key. And then we also think kind of, and at this point, I'm thinking maintaining kind of lots of those chronic cardiovascular diseases, like making sure your diabetes and your hypertension and your hyperlipidemia are well controlled, are really key to potentially preventing or minimizing risk. I think is probably the way to phrase it when talking about decreasing your risk for dementia. The Mediterranean diet is one we recommend, and then any exercise somebody's willing to do. Again, mobility is key to not only maintaining your body but maintaining your mind. And so those are just kind of broadly speaking, without having a specific person in front of you, those would be two things that can really help with prevention or maintenance of mentation. Jessica, do you have something to add?
Yeah, I'm also gonna, plug in the medication piece of it. There are medications that are linked with increasing risk of dementia and confusion, which are anticholinergic medications, which unfortunately a lot are easily available over the counter, and a lot are used for different disease states in our elderly population. So just kind of understanding those and trying to minimize those as much as you can. So some of the big ones are Benadryl, antispasmodics for bladder, so your oxybutynin, things like that. And then of course our benzodiazepines and those medications as well. So always trying to minimize those when able to. Of course, sometimes there could be exceptions, but overall trying to minimize those as well.
Cool. Thanks for the question, Rick. I really appreciate it.
What about things like any kind of neuroplasticity, exercise, engagement, luminosity, stuff like that? What are your thoughts on that?
So I guess long answer short would be not really clearly supported by the evidence at this point. I think is just the general answer. I think there's a lot of pros to staying engaged and staying active and having meaning to your life, and I think lots of these apps can provide that as well. And so I don't think there's anything harmful from these apps, but I'm not sure there's anything helpful either from a mentation standpoint. All right. Well, we'll kind of leave it at that, and again, we'll kind of be referring to an age-friendly health system as we kind of continue along with our talk today, the 4 M's, and with that, Leslie, I think it's all yours.
All right, thank you. So I'm going to be presenting a case with a discussion that will demonstrate the similarities between geriatric and palliative pharmacy, pharmaceutical care. We will see as what matters to our patient as that changes. So does the approach with medications, and we will transition into a more palliative care approach. So GP is our 73-year-old male, was admitted to a skilled nursing facility following a hospitalization for a ground level fall that resulted in a hip fracture, and he is status post revision internal fixation for that broken hip. Next slide. Okay. So his functional status, pre-hip fracture, he was living independently in his own home. He was independent in his ADLs, and his IADLs, he was dependent for shopping, finances, and cleaning, but he was independent in his medication management, telephone use, and cooking. Post-hip fracture, he's being discharged from acute care hospital to a SNF for rehab. His ADLs, he needs assistance with transferring, ambulation. He's currently in a wheelchair. He needs assistance with dressing, toileting. He has functional incontinence due to that broken hip. He needs assistance with bathing, and he is independent in eating and swallowing. And his IADLs really haven't changed much, except for if he were living independently, he would need help with a pill box. Next slide. His active problem list is a right hip fracture, so he is non-weight bearing for 6 weeks. He has osteoporosis. He is oxygen dependent due to COPD. He has a 50-pack year tobacco history, and he is still smoking. He has osteoarthritis in his lower back and hands, and that arthritis in his hands makes it very difficult to use the inhalers properly. He has high blood pressure, type 2 diabetes, and his most recent A1C is 5.9. Complications include stroke. He's got peripheral neuropathy in his hands and feet. However, he does not have retinopathy or nephropathy. And he's had 3 hypoglycemic episodes recently. He also has BPH, and his mild cognitive impairment, issues with executive function. So he has trouble with tasks that require more than 3 steps. So driving to a new location, or maybe communicating decisions that were made at a healthcare appointment with his family. Next slide. He's had recurrent falls. He's had 4 in the last 6 months that are multifactorial, including episodes of hypoglycemia, the neuropathy he experiences, chronic pain, polypharmacy, and cognitive impairment. He has depression, decreased oral intake, and he's lost about 30 pounds over the last 2 years. And he has no medication allergies. Next slide. And as you can see here, he's got quite an extensive medication list. He is on 3 inhalers in addition to the oxygen for his COPD. He is on 2 medications for BPH. He is on 2 blood pressure medications and cholesterol lowering medication, insulin and metformin for diabetes. He's on omeprazole for heartburn, and he is on 3 pain medications, so oxycodone, acetaminophen, and meloxicam. Also takes a medication at bedtime, trazodone for sleep, and full dose aspirin for a blood thinning agent. And he also is on 2 over-the-counter dietary supplements. So he's got quite a medication list going here. All right, so what matters to GP? He would like to transition from his skilled nursing facility to living independently in his own home with the assistance of a caregiver 2 hours a day. He also wants to start helping his son stock shelves in his new store. He's got current advanced care planning done, a pulse in place, and he is full code with no tube feedings. Next slide. His physical exam, a heart rate 75, blood pressure on the low side at 101/63. He has O2 sats of 90% on 2 liters of oxygen via a nasal cannula, and his BMI is 24. He is alert and oriented ×4. And the delirium screen was negative. However, it was positive for some disorganized thinking, but negative for acute or fluctuating status. His MoCA, or the Montreal Cognitive Assessment Test, was 26 out of 30, and that indicated that there was some executive function issues going on there. And his hip incision was clean, dry, and intact. So when I do an assessment of somebody, I always want to go back to what matters to that patient. So reviewing again, GP wants to live, transition from the SNF into living independently in his own home with the assistance of a caregiver, and he wants to start working with his son. So he really has a lot of motivation, as somebody had pointed out, to get on the road to recovery and start moving forward. And the overarching goals I think that we want to look at is minimizing medications that are going to increase the risk of falls, reducing polypharmacy, because we know that the more medications an older adult takes, there's a higher risk of drug interactions, adverse events, functional decline, non-adherence, a decrease in cognition, and an increase in falls. So especially that falls point is really important for GP. And then we want to make sure we have adequate pain control and optimizing physical function to align with what his goals are. So looking at all of this, we're going to look more closely at the medications that he's taking. Next slide. So I really, first off, would focus on hypertension. We know that another fall for him would really be a catastrophic event potentially. So hypertension and the current blood pressure that he has right now warrants some looking at. So current blood pressure ranges are 96 to 100 over 50 to 63. Currently, he's receiving terazosin 10 milligrams at bedtime, and then lisinopril 10 milligrams once a day. And if we look at what the current guidelines are for the treatment of hypertension, the guidelines from 2017 from the American Heart Association and the American College of Cardiology, they set a blood pressure goal of less than 130 over 80 for adults greater than 65. But then if you look at the guidelines published the same year from the American College of Physicians and the American Academy of Family Practice, they have a target systolic blood pressure of less than 150 for folks over 60 years old, and SBP of less than 140 if they've got a history of stroke or an increase in cardiovascular risks. So we really have a range here. And I think it's important, again, going back to what matters to that patient and what are our goals of therapy. And then for him specifically, is there a lower limit for what blood pressure should be? And there really is no given number for what blood pressure should be, but we really look at more of, are they experiencing falls? Are they having syncope? Are they dizzy? Are they fatigued? You know, are we seeing side effects from having that blood pressure being so low? So what matters to GP is living independently at home and helping his son. So we know if he experiences another fall, remaining and living independently will be extremely difficult. So while we want to minimize the risk of having another stroke or a cardiovascular event, we want to make sure that we're not keeping that blood pressure so low that that's going to have him cause him to have another fall. So looking at the recommendations for him, thanks, Troy. Discontinuing terazosin would be the first choice. He's had 4 falls in the last 6 months. And the reason we look at terazosin is it is on the Beers criteria as a potentially inappropriate medication for an older adult due to orthostatic hypotension. And I think Kelly had mentioned earlier, she would like to see orthostatic blood pressures to really see what's going on, and is that causing some of his falls maybe. So once we discontinue that, we want to make sure that we're monitoring his blood pressure and optimizing that lisinopril dose. And it may be that he doesn't even need to be on a blood pressure medication. He's lost a significant amount of weight in the last couple of years. So it could be that he will be fine without any blood pressure medications. So again, decreasing those number of medications is an overarching goal for him. And then if he's willing to look at lifestyle modifications, I would recommend the DASH diet. So that is the dietary approaches to stop hypertension. And basically that is a diet that's rich in vegetables and fruits, high fiber foods, and lean protein sources. So it really is dependent on whether he's willing to try that lifestyle modification, or if he wants to just control blood pressure, maybe with medications if those are necessary. Okay, next slide. And then the second thing I would look at is his type 2 diabetes. So his current A1C is 5.9%. So the A1C is giving us an idea of what his blood sugars have been running over the last 3 months. And he's also had a 30-pound weight loss over the last 2 years. So that is probably affecting that diabetes. His current treatment for that is metformin, 500 milligrams twice a day, and insulin glargine, so a long-acting insulin. He's getting 10 units at bedtime. And the first thing that I want to take a look at is what are the choosing wisely recommendations for geriatrics, and that looking at the A1C goals. So they break it down into 7 to 7.5% for a healthy older adult with a long life expectancy, 7.5 to 8% for somebody with moderate comorbidities and a life expectancy of less than 10 years, and 8 to 9% for multiple morbidities and a shorter life expectancy. And the other part to choosing wisely is they do not recommend using any medication other than metformin to achieve an A1C of less than 7.5 in an older adult. And we choose metformin because the risk of having a hypoglycemic episode with metformin as a single agent is pretty low. So our GP is on metformin, which is fine, but then he's also on insulin at bedtime with an A1C of 5.9. Give me the next slide, please. So those, what we just went through, were the choosing wisely A1C goals. And these are the 2020 American Diabetes Association standard for care in diabetes for older adults. And if you look at these numbers, they are very similar to what the choosing wisely recommendations are for a goal A1C for an older adult. It's important to consider what the patient preferences are. What is he willing to do, or what is that person willing to do? And then also their health status and what their preferences are. And those may change as time goes on. And we will see that when we get into Jessica's portion. So I would say for him, you know, he's, I think as pointed out, he's got a lot of different disease states. And so looking at what an appropriate A1C for him is, you know, I would say using the ADA guidelines, around an 8% would be appropriate for him. Okay, next slide. So the recommendations that I would have for him are discontinuing the insulin glargine to minimize the hypoglycemic episodes, and then also minimizing polypharmacy. I would also, because that A1C is so low for him, I would discontinue the metformin to reduce polypharmacy and then recheck an A1C again in 3 months and reevaluate where we are with the diabetes and if medications are needed. Next slide. So with GP, minimizing falls is the priority for him, so he can work towards living independently and working in his son's store. Having said that, there's also other considerations. to improving his medication regimen and reducing polypharmacy and potentially the risk for falls. We want to try and make one medication change at a time. So we can't solve all of the problems in this transition from the hospital into a skilled nursing facility. But I just wanted to point out some of the other considerations that I would have in looking at his medication list. So he has osteoporosis with a hip fracture, and he has no preventative medication. So this is a case where I would actually add an additional medication. And I think as a prescriber, when you see a med list like that, that GP has, there's some hesitation there with, do I really want to add one more medication to that list? But this is a case that I would certainly evaluate for adding a medication for. He's got COPD, and Jessica is going to talk a bit more about that. We'd also want to look at his sleep and the need for a medication for GERD and the supplements that he's taking, and then also the need for the cardiovascular medications at the current dose. So I think at this point, I'm going to turn it over to Jessica to talk about what happens next with him.
All right, thank you, Leslie. So just to recap, so we had GP, he fell and broke his right hip. He was able to be discharged back home as his goals following physical therapy. He had some medication changes to optimize his medication regimen with recommendations for further changes at his follow-up with his primary care doctor. Unfortunately, our patient GP did fall again about 8 weeks later, which resulted in a left hip fracture. And he is now status post open reduction surgical repair on that left hip fracture. While he was hospitalized following surgery, he also suffered an aspiration pneumonia, which has compromised his COPD and breathing further. He's admitted to the skilled nursing facility for further rehab at this time. Next slide. And with that, he has had a significant decline in his functional status, unfortunately, after this second hip fracture. He is fully dependent with his ADLs and IADLs, and this is requiring around-the-clock nursing care. He is incontinent of bowel and bladder. At this time, it's likely more functional than related to his cognitive status, though that has been noted to decline as well. And he is declining to work with physical therapy due to pain and shortness of breath. So because of these significant changes with GP, the team has began to discuss with the family and the patient himself what maybe his goals are and to see if those have changed now after this second hip fracture with ongoing decline. So looking at his medication list, a couple of changes. We did just continue the insulin and the metformin, as Leslie had discussed, and we stopped the terazosin. He also, in the interim, was transitioned from the budesonide formoterol to a combination of just the olodaterol tiotropium. The reason for this, there is limited evidence to support the use of inhaled corticosteroids in COPD with an increased risk of pneumonia in those patients if they don't have an underlying inflammatory or asthmatic component. So in our patient, we were able to get rid of the budesonide formoterol, which is a twice-a-day inhalation, transition him to a combination product, which is just once a day. So that did minimize his medications as well and minimize risk of pneumonia. We also decreased the omeprazole frequency, and he continues on the albuterol inhaler, those high doses of the atorvastatin and the aspirin, finasteride, and as well the high dose of tamsulosin. He was agreeable to stopping his rose hip supplementation, but he still continues the B12. And then his oxycodone has also increased from the frequency of 3 times a day to 4 times a day as needed. Next slide. So now, like I said, the team has been looking at maybe changes in what matters to GP and discussing with his family his goals of care. At this point, he wants to be comfortable and he wants to discharge home with the family for his remainder, however long that may be, at home to be comfortable. His advanced care planning has changed a little bit in that he no longer wants to be hospitalized and he is DNAR. So looking at his physical exam, overall, his blood pressure still remains on the low end despite getting rid of the terazosin. His oxygen requirements have increased from 2 liters up to 4 liters to maintain that oxygen saturation of 90%. His BMI has also decreased from 24 to 22 over these last couple of weeks. And his delirium screen is notably negative, which is something important to consider when you're talking about goals of care and end of life discussions with patients and making sure they're in the right state of mind at the time that they're making those decisions. The cognitive screening was deferred as it was performed just 8 weeks prior. His MMSE was 26 out of 30. He has now been hospitalized, had surgery again, and is now back in the skilled nursing facility. So at this time it was deferred. He does have severe pain to his left hip with all range of motion. Both incisions on the left and the right hip are clean and intact, no signs of infection. But with that pain, that is severely limiting his function and his quality of life. And lastly, his pulmonary status. He has an increase in the effort with no use of those accessory muscles. He has some right lower lobe crackles noted with diffuse expiratory wheezes and a prolonged expiratory phase. So next slide. So we can skip this slide here. We'll go right into kind of his COPD. So one of the biggest things that I wanted to bring up when we're managing COPD and kind of that air hunger that we can see when we're reaching more of end stage COPD, and especially in someone who's had some insults with his aspiration pneumonia and worsening oxygenation and things like that, we can consider using morphine for air hunger. It is our gold standard treatment due to various different mechanisms of action. It diminishes the chemoreceptor response to hypercapnia, reduces pulmonary vascular congestion, and decreases the central perception of dyspnea. So it really can be very helpful, and in our patient we could use it both for pain and shortness of breath. And then of course second line could be benzos if there's an anxiety component related as well. An additional non-pharmacological intervention could be just the use of fans. It's been shown that using a handheld fan can really trick the brain into alleviating dyspnea, which and can reduce the sensations of breathlessness. So that can be a simple intervention that you can use for your patients both in a facility and at home. And you can use oxygen if they're hypoxic, but it's not been proven to be beneficial in the setting of non-hypoxic patients. So that's kind of one of the big things that I wanted to just touch on real quickly, because in our patients, in geriatric patients and for the most part across the spectrum in elderly, we do try to avoid opioids. But in patients that are more looking for that improving quality of life and improving their air hunger and pain, you can use low doses of opioids for them as well. So we can kind of skip through. With the opioid dose conversion, he was on oxycodone 5 milligrams. So a direct conversion to morphine would be that 7.5 milligrams. That's a direct oral morphine equivalent to 5 milligrams of oxycodone. So I would start with that in this patient because he has been tolerating it well, though it's not treating his pain or helping with his air hunger at this point. So we would start at that dose and titrate up if needed, depending on his relief in pain as well. And you can optimize his Tylenol dose as well to 1,000 3 times a day. And then lastly, just some other things that you can look at in our patient to further minimize medications. We can go to the next slide, Troy. Stopping finasteride, especially now that we're talking more limited prognosis, that can be stopped, and we can still see effects of the finasteride even after stopping, as the conversion with the testosterone and the effect on the prostate can take months. And it would also decrease that tamsulosin dose to further minimize fall risk, as well as the lisinopril. The aspirin and the atorvastatin, he doesn't have any known clinical ASCVD, so heart attack, stroke, anything like that. So stopping those medications would likely be appropriate at this time with his prognosis, as well as the B12, depending on kind of his willingness to stop that supplement as well. Some deprescribing resources that'll be on the slide, available for the slides. The one, the medstopper.com is a really cool resource. You can just plug in medications, and then those, it will kind of walk you through what may be the most important one to get rid of, or the ones that are less safe than others. So that's a resource as well. And again, I do apologize that I was not paying attention to the time when we got to my point. So next time I will talk faster. But I did want to say that we do have the Palliative Echo, which is every third Friday of the month. So we do talk more about some of these topics, and the one that will be this Friday is nausea and vomiting. So if anyone wants to join that, we will kind of be having a really good discussion on managing nausea and vomiting in the palliative care setting. And each month we try to target something else, different topics, and those can also be found on the website as well.
Great. Thanks, Jessica. Thanks, everybody, for sticking with us a little bit after time today. We'll open it up right now for questions or discussion. Does anybody have anything that they want to talk about?
The one thing that I kind of wanted to bring up with regards to an age-friendly health system, just kind of hearing what other people, kind of the discussion that's been going on, and just to kind of, and again, this is just to share my experience, as we really focus on what matters to our patients and to the people that we're providing care for, the things that matter to us really start to become not as important, and so often when people decide what matters most to them, they're going to be increasing their risk for a lot of things, potentially falls, potentially confusion, potentially delirium. And it's us to just kind of educate them about the risks that they're taking as we continue to support them with what matters. And like Jessica mentioned earlier, if unfortunately when somebody has one fall in the community, 2 out of 3 of them will fall again. And we need to really minimize that risk of fall and do our best, just like I think Vaniqua and Sarah were saying. And so completely agree with everything you're saying. But at the same time, if what matters to the patient, like stocking boxes on shelves, for somebody that just broke their hip, that's probably going to increase their risk of falls, even as we support them and kind of educate them about that risk. It's just kind of a balance game that we continually have to play.
Thanks, Dr. Levy. Any other comments or questions from the group? Alrighty, I think we'll wrap up for the day. I'll make some quick announcements at the end here. So this is our Geriatrics Echo Clinic webpage, where you'll find everything from today's session. So if you go down a little ways, you'll find the link to download the slides. This is that link there. And then there's a link to claim AMA, PRA Category 1, Nursing, or BELTCA credit for today's session. So please complete that evaluation to claim your credit. I also sent out the link for that through the chat box. And then, as Jessica mentioned, we also have our Palliative Care Echo series. That one's going to be coming up this Friday at 12 to 1 p.m. with Drs. Brogan and Dr. Mila talking about nausea and vomiting. And you can see we've got a short cancer series coming up through that one as well. So a lot of great resources here through Project Echo for you to join. And then, Dr. Levy, do you want to talk about our next geriatric series session?
Sure. We're planning some new things with our Geriatric Echo. We're hoping to launch that here in the late fall, early winter. But in the meantime, we're probably going to be offering some COVID-related topics for our next 2 sessions. We don't have them on the calendar yet. We have a meeting, I think, later this week, and we'll kind of get all those scheduled. But really want those cases. If you guys have any cases, feel free to fill out the case review form as much or as little as you can. But yeah, we'll look forward to some COVID-19 related topics with regards to geriatric care here for the next few months.
Excellent. Thanks, Dr. Levy. So yeah, thanks everybody for joining us today. Really great session. Glad to have you all participating in the discussion as well. Don't forget to claim that CME or CEU credit if you need it. And I'm going to send out a quick poll that will show up through Zoom just to give us some feedback on how you thought the session went today. Thank you all. Take care. Bye-bye.
Yeah. Thank you, Leslie. Thank you, Jessica. Great job today. Really appreciate your time and your expertise.
Thank you, everyone.